TOG 2025 Issue 3. An update. What's new in guidance? Evidence-based management of patients with endometriosis undergoing assisted conception. Endometriosis is a chronic inflammatory condition that affects approximately 10% of women of reproductive age. It contributes to infertility through anatomical distortion with pelvic adhesions and tubal blockage. Ovarian endometriomas, which are prevalent in up to 50% of women with the disease, can reduce ovarian reserve, evidenced by lower serum anti-Müllerian hormone level and antral follicle count compared to women with healthy ovaries. Surgical excision of endometrioma further diminishes ovarian reserve, with greater impact in cases of bilateral disease or repeat surgery for recurrent disease. Endometriosis-associated infertility is multifactorial, with advanced maternal age, tubal blockage and failure of expectant management increasing the need for assisted reproductive technology procedures, such as IVF or ICSI. There is inconsistent evidence regarding the impact of endometriosis on pregnancy outcomes in ART. To address this, the British Fertility Society Guideline Development Group developed an evidence-based guideline on the management of patients with endometriosis before and during ART with the aim of improving pregnancy outcomes. Figure 1. The pre-ART management options for endometriosis-associated infertility branch into hormonal therapy, surgery, and complementary therapies. There is no evidence to support the role of complementary therapies. For the adjuvant hormonal therapy and GnRH analogues, there is uncertain evidence for improving ART live birth rates. Meanwhile, the benefit of surgery depends on the endometriosis grade. In case of minimal to mild and severe disease, further evidence is needed to confirm benefit for ART. Therefore, routine surgery for minimal to mild and severe endometriosis before ART is not recommended. Surgery for severe endometriosis carries significant risks, especially when associated with bowel involvement. However, for endometrioma, routine excision is not recommended because there is no strong evidence to support it in order to improve pregnancy outcomes. Surgery may be necessary to improve access for oocyte retrieval during ART and for symptom control, but no definite size threshold can be recommended. Post-operatively, the adjuvant hormonal therapy and GnRH analogues can be considered to prevent symptoms and disease recurrence after surgery. After surgical management of minimal to mild endometriosis, intrauterine insemination may be performed with gonadotrophin stimulation before ART, but there is no evidence for benefit in severe disease. Figure 2. Management of endometriosis during ART. For pituitary downregulation during ART, both agonist and antagonist GnRH analogues can be used. The longer GnRH agonist may be considered for symptom control after surgery, but with caution in reduced ovarian reserve. There is no superiority of other methods for pituitary downregulation, such as oral progestogens, over GnRH analogues in endometriosis. For ovarian stimulation during ART, no one superiority of gonadotrophin over another. Specifically, there is no superiority of urinary versus recombinant versus human menopausal gonadotrophins. For oocyte retrieval during ART, there is insufficient evidence for routine use of antibiotics, but antibiotics should be considered when there is an endometrioma, in order to reduce the risk of pelvic infection or tubo-ovarian abscess in case of inadvertent puncture. Elective aspiration of endometrioma at the time of oocyte retrieval is not recommended. For fertilization during ART, there is insufficient evidence to recommend ICSI over IVF when sperm parameters are normal. For the luteal support during ART, there is insufficient evidence to recommend any particular luteal support for women with endometriosis, compared with those without endometriosis. For the frozen embryo transfer cycle, there is insufficient evidence to recommend natural, modified, or artificial cycles with or without GnRH downregulation.